first flex-arm surgical holder and positioner was used in 1974 by a gynecological laparoscopist. Back then, before we saw the use of video cameras in laparoscopy, the surgeon looked through the eyepiece of the scope. This prevented anyone else in the room from seeing the operative site and prevented anyone from assisting in the surgery. Additionally, the surgeon used his or her left hand to hold the scope. This allowed only one instrument, a probe, scissors, or bipolar forceps, to be used at any given time. By utilizing the flex-arm holder, the surgeon was able to use two instruments simultaneously. At that time, a huge improvement in operative laparoscopy. The introduction of video laparoscopy did not diminish the use of the flex-arm device. Rather, the arm enhances the procedure by steadily holding the scope or camera, no drift or no inattention by the camera driver. Arms can also hold graspers and retractors, resulting in their most significant benefit to the surgical facility, labor savings. This video will examine those benefits and review the three most popular mediflex flex-arm holders and positioners. We'll look at what they have in common and we'll explore the differences between the three arms. Several significant advantages to using the mediflex flex-arm system. First is the potential labor savings by eliminating one or more staff members who currently are in a laparoscopic procedure just to hold the laparoscope or a grasper. Secondly, we find that the arms reduce surgeon frustration by not having the laparoscope drift. The arm is easily repositioned by the surgeon. This allows them to make movement of their camera, and when they let go of the arm, it still holds very steadily. We have a wide variety of scope and instrument holders ranging anywhere from 3.5 to 12.5 millimeters in diameter, all of which can be interchanged with our quick disconnect accessory system. Our arms are adaptable to many types of patients and procedures by conforming to virtually any setup position desired. And all mediflex flex-arm devices are of the highest quality and reliability as they are manufactured in our ISO 13485-2003 facility. Here are the three most popular flex-arm devices. This is the original one-piece system. It is basically unchanged from 1974 and is still widely used today by surgeons around the world. Many years ago, we developed this device for Codman. This was part of their Bookwalter table-mounted retractor line, and we now market it under the Mediflex brand and call it Bookler table-mounted retractor. Some of the advantages of this system are that the post will be able to be adjustable in height. This coupler, when loosened, allows the entire system to be moved easily and slid up and down. The other big advantage of this system is that these table posts come in several heights. This is a 12-inch post, there's an 18, and there's even a 24-inch post. And we have the ability to attach an extender to that. We're finding this is used primarily in bariatric surgery where the surgeon needs to get this arm way up over the large patients. Our third most popular item is called a long reach. This was also developed for bariatrics by allowing the surgeon to place the flexible arm onto a bar that can be raised and put out over the surgical field. The other advantage of this system is that a second or even a third arm can be positioned on this bar, allowing, say, in lap chole, the surgeon to hold both the laparoscope and the fundus grasper. So we'll look at some of the things that these have in common, and we'll look at some of the differences as we now progress. All Mediflex flexible arms consist of a series of knuckles, or ball and socket joints, that are built around a twisted wire cable. When the cable is loose, the arm is very movable and can be positioned in virtually unlimited numbers of positions. When the cable is tightened, tension is applied to each joint, and the friction causes the joints to resist movement. Now, each of the three arms we looked at has its own tensioning knob. On the first instrument we looked at, the original one piece, the tensioning knob is right here. This is what is turned to loosen and tighten the instrument. On the Bookler system, here is the tightening knob. And on the units that slip onto the long reach post, here is the tightening knob. They all do exactly the same thing. Now, every FlexArm device is designed with a cable that is actually slightly longer than necessary. This is done for two key reasons. Over time, as you tighten the cable, it tends to stretch slightly. Or the open ends of the knuckles, when they're forced together time after time, tend to bell out slightly. This, in effect, shortens the overall length of the outer part and lengthens the cable. If there were no way to take up the excess slack in the cable, the arm would not be able to be tightened to its design maximum. Now, a second clinical reason to allow the knuckles of the arm to be spread open is for cleaning and sterilization. By having the spaces that you see here, detergent and sterilant can get inside the cable to thoroughly sterilize it. To make the FlexArm series of products work correctly, we have to do something called pre-tensioning them for use. Now, this arm has been pre-tensioned. If you notice, there's no opening in any of the knuckles, there's no slack. As I rub my fingers up and down, I don't hear any noise whatsoever. This arm has not been pre-tensioned. You can see as I rub my fingers up and down, you can hear the sound the ball and socket joints make falling into each other. You can actually see the cable at least one point in the arm. So this device needs to be pre-tensioned. All the arms you've seen so far are slightly different designs, but they're all opened and pre-tensioned in basically the same way. And here's how you do it. First, make sure that the arm needs to be pre-tensioned, as in this one. If you can hear the knuckles, it needs pre-tensioning. Check to make sure that the tensioning knob, the device we saw before that tightens the unit, is all the way loose, and that is turning it in a counterclockwise method until it reaches a stop. Now hold the distal end in your left hand, or your right hand if you're left-handed, and turn the entire housing at the proximal end, not just the tensioning knob, but this entire housing. What this is doing is allowing the internal mechanism to pre-tension the cable. And you'll do this until you start to feel some resistance. And I'm feeling that now. And now when I hold it, it is pre-tensioned. There's no movement in the knuckles. This arm is ready to use in surgery. Now, before you send an arm for cleaning and sterilization, we need to open it back up again. And the method to do that is exactly the opposite. Again, make sure that it has been loosened at the tensioning knob all the way, turning it counterclockwise, and then holding the arm in your left hand, twist the entire housing in a counterclockwise manner until you see space begin to appear and the cable is visible. Each of the devices is done the same way. The one-piece arm right now, it's pre-tensioned. I would be able to open this by spinning the entire housing counterclockwise. And now I have the space that's necessary for cleaning and sterilization. When it comes back to the operating room, make sure that the tensioning knob is all the way counterclockwise, and then spin in a clockwise manner until you meet resistance, and the arm is now pre-tensioned. Our buckler arm is done in the same way. The folks in SPD will loosen this for sterilization. You receive it in the OR, you do the test, it is opened. Make sure that the tensioning knob is all the way counterclockwise, and then spin the entire housing in a clockwise fashion until you meet resistance. And now we have it pre-tensioned and ready for use. And when you don't have the tip locked in securely, it falls on your foot. Now, it's real important in the OR when you're done to prepare this for the cleaning process by, number one, turning the tensioning knob all the way counterclockwise and then spinning the housing to open this up for cleaning and sterilization. We don't always assume that the folks in the cleaning department know about this, so it's best that it be done in the OR. One caution, however, never open this to more than about 1/4 of an inch of visible cable. If I were to continue to open this by spinning counterclockwise, eventually the cable would come off a thread that's internal, and you would have 18 or 20 of these little knuckles rolling around the floor of the OR. So it only needs to be opened between 1/8 and 1/4 of an inch for sterilization. Don't over loosen it to the point where it literally will come apart in pieces.